Here comes part two of my three-part interview with Dr. Peter McCullough. If you saw part one, you know what an extraordinary, gifted individual this is, and thank goodness he's willing to share what he knows and understands with you and I. Part two is extraordinary, and there will be a part three to follow, but let's do part two right now. How'd that go for you, your personal journey in COVID? So you did the protocol, pretty much that you were recommending?
I did the protocol, and I suffered, not to spend too much time on it, I suffered on some confused information where I was very ill in February of 2020, and I made a trip to California. I was under the impression I may have already had it. I was involved in some earlier research in my center where we're using experimental antibody assays where I had some antibody assays that were positive. So I was under the impression that I had it. But the evidence wasn't very strong. And then sure enough, my wife got it, had the close contact. It was clear I got it. At that point in time, I got an FDA-approved test. I had it, and I had all the characteristic features. And I got going on early treatment. It was a bit late, but I almost certainly had some pulmonary involvement. I had shorter breath, and I made a video. I exercised and just to kind of show everybody when one has COVID, you're away from people outside, but if you try to exercise, which is actually not a bad thing to do, as long as one doesn't have a fever, it's actually a good thing to do, how shorter breath one can be. Just to show that, I look back and I say, wow, I was really shorter breath. And I went through a sequence of drugs involving hydroxychloroquine, azithromycin, the nutraceutical supplements, either colchicine or placebo, and then corticosteroids. So a pretty good program. Wasn't hospitalized, my wife wasn't hospitalized, so now we had 3 of my family members had been through it. And I was tightly communicating at that point in time with Senator Johnson, and Senator Johnson strongly believed that this was a time for doctors' judgment, that doctors' judgment was going to be critical to the pandemic response, and that we just could not sit back and wait to be told what to do because no one was telling us what to do. I mean, there was just no guidance. People were getting test results and going home with no guidance and just saying, listen, if you get sick, show up to the hospital. And that was the state of affairs from March of 2020 all the way through to the historic Senate testimony hearings.
Well, let's talk about those. So what happened there?
Well, I have to tell you, I did have a moment in time of understanding what was going on. So I had gotten the letter to show up in the Senate and present. And that letter looks like getting called to jury duty.
Yeah.
And it comes on letterhead. It says you will appear. You have 5 minutes, and you must submit a 700-word, speech of what you're going to say. It's pretty well circumscribed. I said, I have a critical figure to help America understand about viral replication, cytokine storm, and thrombosis that I've got to show on the Senate floor. I need to do this, but I want to be able to cite it. So I knew the importance of publishing because I'm in this business. This is what I do. So, and not that, but we had data on ivermectin. We had data on monoclonal antibodies coming. We had data on colchicine now, very supported, inhaled budesonide. And these supported by clinical trials, inhaled budesonide, 2 solid randomized trials, corticosteroids, 12 trials. We are extrapolating from in-hospital, stuff that worked in hospital late, surely could be beneficial early, right? And as well as aspirin and anticoagulants. So I had an update to the second paper, but I didn't have time to reach out to all the authors again and get all their opinions. And just this whole collaboration piece is just time-consuming. It's 1 million emails. Everybody has their own, words they want in there. So I said, I'll do this solo. I'll do it as an update, and we'll publish it in the Proceedings of the Baylor University Medical Center, our own journal. I would get internal peer review. Dr. Roberts is the editor. So I submitted it. They got 2 peer reviewers. It came back, changes requested. I did it. We went through some checks with the deputy editor about overlap with the American Journal of Medicine paper to make sure it didn't overlap too much because it was clearly an update from the first paper. And got past that, and it got full acceptance by Dr. Roberts, and I was going to go to Taylor and Francis, the journal. So I filled out the contract, publication agreement, paid a fee. The fee, as I recall, is like $3,500. It's not cheap to publish. I paid it on my own money. And it's off of Taylor and Francis, ready to get cited in the National Library of Medicine, PubMed, and ready to go. And I'm waiting, because I want the NLM site ID on the figure to show on the Senate floor. And time is coming, time is coming, time is coming. Nothing comes, nothing comes, nothing comes. And I'm running out of time, and I contact Taylor and Francis. Where is the citation? When is this going to be cited? No answer, no answer, no answer. And then finally I get an answer from Taylor and Francis. They go, Dr. McCullough, there's a problem with your publication. You have to talk to the editor. I said, good grief, what type of problem? I mean, this is over the finish line. Once we sign publication contracts, peer review is already done.
Yeah.
Everything, all the checks are done. I mean, this is a done deal. It's actually contractually done. Mm-hmm. So I go down to Dr. Roberts' office, and he goes, it's the first time I've seen this in my 50 years of editing. I said, what? I said, the National Library of Medicine pulled this out and said the paper can't be published. I said, why? He said, too much overlap with the first paper. I said, we've already been through that. I already went through the checks. Sorry. He goes, I've never seen it, but it can't go forward. I said, good grief. So I went to the U.S. Senate without having the NLM site ID. I had an original date of issue from Baylor proceedings, and I just had to go with that. And I went forward with the Senate testimony to finish the story on the paper. I felt like, wow, things are starting to really work against publishing any information on early treatment. So not only was my paper in the American Journal of Medicine pretty lonely, there were no other protocols. We didn't see a Harvard protocol or Mayo protocol or protocol from Karolinska. We didn't see any protocols from Italy. There were no protocols. No one was publishing different protocols. You can imagine if this was a cancer, there'd be 17 different protocols. Everyone would be touting that they've come with an approach. All of our U.S. medical centers would be so proud to say that they are saving Americans from being hospitalized. That it was none.
Is your interpretation it's not for a lack of people trying, but that they're not allowing it to get published?
Well, hang on. To my knowledge, I don't think these medical centers even tried any protocols.
Wow, okay.
Because none were listed by the clinicaltrials.gov. So not only did we didn't see any papers, we didn't see any people out there saying, yes, so-and-so, come to the Mayo Clinic and you'll be one of 3 of our outpatient protocols to prevent, keep you from being hospitalized. We didn't see this anywhere. You probably don't remember any being advertised.
No.
Nothing was offered to Americans from our major medical centers, which is really shocking. Our major medical centers offer something to everybody. They have programs for every illness under the sun, but suddenly for this one, it was just a complete lack of academic effort.
Yeah.
So I even felt more implored. I said, geez, if I'm the only one who can get a paper published on how to treat COVID-19, the update's super important because we had the emergency use authorized antibodies. These were as good as we're going to get. They were the first FDA-approved new technology to treat COVID-19. New technology, first one. So what I did is to finish the story on the paper, I said, you know what, maybe I'm just taking too much on my own shoulders. I reached out to the doctors who were treating COVID-19 with all their innovations. Say, you know what, I want your opinions. Dr. Vladimir Zelenko, he was one of the original innovators. I didn't have a relationship with Dr. Rialt, so I didn't reach out to him. But many others, Brian Tyson, George Fareed, I can go down the list, Yvette Lozano, Stella Manuel, they were just all these, now they're the kind of iconic hero figures treating COVID-19, and asked for their opinions. I recognize many of them weren't hardcore academicians, but I had others that were really, I had Dr. Charles Geyer, who was down at Texas Medical Center down in Houston, wonderful academician. I had just terrific academic input, made even a better paper. And then I started to feel as if I was getting worried that I actually could not get this published. I started to get a sense that I couldn't get a fair deal. So I commissioned a separate COVID dedicated issue to reviews in cardiovascular medicine, and I convinced the acting deputy editors that this is important. They had to be funded by the journal. And then invited not only this paper, but a whole array of papers on COVID-19, largely how COVID influenced the heart. But this had a separate editor assigned to it. That editor had free hand in assigning its own reviewers. Many reviewers were assigned to it. It was heavily peer-reviewed, tons of comments, a big, long rebuttal letter to handle all the comments. I mean, this is the vetting process that it goes through. And that paper was published in the December issue 2020 in Reviews in Cardiovascular Medicine with the update. And to this day, those 2 papers become really bedrock foundation for protocols. In fact, the first paper became the protocol that the Association of American Physicians and Surgeons utilized for the first home treatment guide.
Oh, wow.
Dr. Lee Vliet and Dr. Jane Orient published that, and I helped oversee it to make sure it was accurate, that we had the doses and drugs right. That document was downloaded countless times and utilized probably enormously, passed from person to person to actually, so Americans could start to know what drugs could they use as an outpatient. The second paper now really had terrific. It had the monoclonal antibodies up front. It had the use of hydroxychloroquine or ivermectin, and then outside the United States, we had 5 countries already using favipiravir, an oral drug. It moved into inhaled budesonide, oral prednisone as an example, colchicine, and then down to aspirin and the anticoagulant. So it was basically the full suite of drugs that we use today. So that went on, and I was gearing up. I was recovering from COVID, but I was gearing up for the first set of Senate hearings. And the decision was, we were worried. We actually had already had some activities. I told you about YouTube videos and things being scrubbed, and having some conference calls being hacked, and Zooms and things not going well. So we had decided, we're not going to do it by Zoom. We're going to go there in person. So I flew, first time I had flown since the pandemic, I believe. I flew from Dallas to Washington. Harvey Risch came from Yale. He drove down with his wife, and George Freed flew in from Southern California. So we flew in, and we were the witnesses for the majority, which is chaired by Senator Ron Johnson. The minority, Gary Peters, chose an academic physician from the Northeast to present, in a sense, a counter-argument. And in that hearing, Gary Peters did say that, he's warning Americans about misinformation. So we were already kind of put on cue that, well, wait a minute, as we try to cite the literature and what the evidence, what we know, that it's possible whatever was said there could be construed as misinformation. But so here we go. Who decides, right? So we made our case that patients should be treated with sequential multiple drug. We had great data on hydroxychloroquine. The counter-argument was largely, you don't have enough evidence. You don't have enough evidence. In fact, it was really what was held in the counter-argument was the only evidence that we're ever really going to have are from large, high-quality randomized trials. We're talking 30,000, 40,000 patient clinical trials, and those only exist with the vaccines. And in fact, the vaccines, and this was November 19th, this is before, obviously, the vaccines were brought forward, right. But it was clear that was going to be the only evidence that we are going to have. The National Institutes of Health had a hydroxychloroquine azithromycin trial. They started it in the spring. They had shut it down. Within a few months, they only collected 20 patients. They had scheduled to collect thousands of patients. All these other hydroxychloroquine, ivermectin studies were, in a sense, were kind of administratively killed over the year. They never were brought to completion. We needed trials of 20,000, 40,000. I'm a cardiologist. This is what we used to. Didn't see it. We didn't see it. In fact, we were so interested in the early use of hydroxychloroquine that Joe Ladapo from UCLA is the first author, gathered together all the trials stopped early, all of them that declared no benefit to hydroxychloroquine. But hydroxychloroquine was always ahead a little bit in each one of the studies. When you compiled them all together, there actually was a statistically significant benefit, about 25% reduction in the outcome.
So the Senate hearing happens, you get the dissenting voice. It seems like everything is pushing toward a vaccine agenda, and anything that is not aligned with that agenda is misinformation. I mean, is that pretty much the feeling you were getting?
No, but I was wary of the idea that despite our best efforts, that we would be somehow wrongly accused of misinformation. And boy, Dr. Harvey Risch, he was pinpoint on the citations. We had a first author listing. I made the case. There's a picture of me holding up my protocol. My hair's a mess because I'm trying to recover from COVID-19. I'm trying to wear an N95 mask and do all this. And I just said, this can't be controversial. We're talking about prednisone. I mean, we use that for asthma. We're talking about Lovenox. We use that for blood clotting. And aspirin, how can that be a lightning rod here? I was trying to diffuse all this incredible focus on hydroxychloroquine or ivermectin. We absolutely positively know not a single drug is going to cure this problem. We don't have single drugs for fatal infectious diseases. Never. And a mistake would be to say, well, it's all about this drug. And if you can't do this drug, you shouldn't do anything at all. And it almost seemed like that's what the argument was. Well, what had come out in after that is we went about our academic lives. But the minority witness in, I think, what was really a shot across the bow and really a low blow in terms of unprofessionalism, is he took the liberty of publishing an op-ed in the Wall Street Journal, where he called Senator Johnson, myself, George Fareed, and Harvey Risch. He called us snake oil salesmen.
Whoa.
Snake oil salesman. And can you imagine? That's from a junior physician to me.
I was going to say, it's
He's
like
junior.
He doesn't have
He's
the
junior. He
standing
doesn't
to be able
have
to make that assertion.
He doesn't have 650 publications. He doesn't have a major contribution to his name.
Yeah.
And wow, that got into the Wall Street Journal. So the junior doctor is calling the senior doctors snake oil salesmen. And Senator Johnson was incensed. He tried to publish a reply. That never went anywhere. The Senate hearings came out on C-SPAN, but they were systematically blocked. You turn on any of the major media, it's like as if nothing happened.
So let's fast forward to where we are today. There are videos being taken down off of media platforms like YouTube that aren't like somebody in their basement making a video and spouting stuff. We're talking about C-SPAN, at Congress in Washington D.C. recording what's going on there, and that is taken down, saying no, you can't see that. You can't even see what's going on at the Capitol. I mean, so are you seeing now that this anything that's not aligned with the vaccine is the only answer agenda is just being taken away, and there's a tax on the people who have a different point of view?
Yeah, that's an important point. November 19th may actually be a very important historical point, because the whole purpose of Senate hearings are to get information to Americans. It's for America.
Right.
It's not, these weren't closed hearings. There was nothing confidential here. This was actually to America. And especially to not have it even summarized in the major media, and then have a really derogatory opinion editorial from the minority witness, which is really out of, he's a witness. He shouldn't be turning around and then trying to report to America through the Wall Street Journal. That was just dastardly, if you will. It's very unprofessional. And of course, Senator Johnson said, well, what do you think about this? They're calling us snake oil salesmen. And I tried to turn it into a positive. I said, every time there's an innovation, it's met with enormous skepticism. And maybe this snake oil salesman is really just an expression of skepticism, that you really can't do this. I had already received these letters to the editor. I had already seen the skepticism. Like, you can't treat COVID-19. You can't do it. It's untreatable. It's unbeatable. You can't. You have to wait for the vaccine. Well, there was a second Senate hearing on December 8th, and I helped Senator Johnson set up the lineup. Pierre Corey, it had Dr. Jean-Jacques Rochter, who had published the largest and highest quality U.S. study with ivermectin. We had Dr. Jane Orient, Dr. Raymond Ascui, and several others, a bigger panel. And there they came in strong on ivermectin, and Pierre Corey made an impression. He showed up in the Senate floor wearing his white lab coat. And he told America that people were being slaughtered by the virus. He, as an inpatient doctor, which I'm not, he was seeing this happen, and he, as well as Dr. Rusher and others, had concluded that we had to treat this before the hospitalization. They, as ICU doctors, were telling America it's too late to start treatment in the ICU. And Dr. Rusher had already shown, he published his ICON study in Chest, one of the best journals, that ivermectin clearly had an impact. Now, would we have wanted to have $500 million, large-scale, randomized, pharmaceutical-supported Operation Warp Speed trials? We would have loved that, but it would have cost a ton of money and would have taken a ton of time, and we didn't have it. Americans were dying, so we really kicked things into action. There was a whole confluence of things. The AAPS guide was being broadly used. Telemedicine services sprang up. National ones sprang up. Regional ones sprang up. AAPS kept a list of treating doctors. There was even a global list of treating doctors. So Americans started to realize, listen, if my doctor turns me down on treatment, I can find some treatment. Most of these doctors were just calling in for monoclonal antibodies. We had a large number of these monoclonal antibodies. They were EUA approved. Great opportunity to start treatment with those. I love treating with EUA. I have somebody today developing COVID-19, high risk in my practice, getting the EUA antibody. So a great way to receive FDA, EUA, Operation Warp Speed, high-tech, big pharma products. I mean, you can't beat it, right? I mean, that's American ingenuity, and we wanted to highlight that for America, and then follow with these evidence-based sequence drugs. So we had a big curve in December. Now, looking back on it, maybe some of it was contributed by influenza. We don't know, but we know early treatment really kicked in, and that we saw a simultaneous reduction in new cases, hospitalizations, and deaths. And the only thing that can really hit that, in my view as an epidemiologist, is early treatment. Because early treatment cuts down a viral replication phase from 14 days to about 4 days. So the infectivity per person is dramatically reduced. It's the only way to do that.
Right.
Letting somebody sit at home and bake with COVID-19, they're going to spread it.
Yeah.
People are going to come over.
Right.
There's going to be, this is what's going to happen. So we think early treatment had this big crushing effect on the curve. And by February 1, we had fewer than 30 million Americans who had received any form of vaccination. We knew that the vaccine trials coming out, they looked like about 90% vaccine efficacy for all the trials. Recruited pretty low-risk populations that didn't come in contact with COVID. So the rates of COVID occurrence, binary occurrence, were less than 1% in the treatment group and in the placebo groups.
So can we pause on that for a second, because this is a part of what is being touted as data right now, efficacy, 90-95% efficacy, but what do they mean by efficacy? And does it prevent you from getting COVID? Does it prevent you from spreading COVID? And I, speaking of the Lancet, I reviewed an article in the Lancet that really got my attention because they said, let's talk about the elephant in the room. In these trials, they're talking about relative risk reduction, not absolute risk reduction. So can you speak to your views around that?
Sure. So relative risk reduction, or a derivative of that is vaccine efficacy, or VE, is the idea that in theory what it means is, in theory, if you came in contact with COVID, you would have 90% protection from getting COVID. That would be the best possible interpretation. The reality is, if in placebo, less than 1% of people get COVID, that means that there wasn't much of a challenge.
Right.
That meant that if there was 18,000 in a placebo group, they never, it's either placebo is really good, which it isn't, they just didn't get the contact. Okay. So when we're below 1% for both groups, that means the absolute risk reduction is going to be less than 1%. And provided that exposure rate to COVID is relatively constant, and provided over time things don't change, that the interpretation of that is the vaccine program could never impact an epidemic curve. It's impossible.
Yeah, because what that means to me as the consumer now is that my absolute risk, meaning what happened in the trial, but what's going to happen to people out here in the real world if you extrapolate, is that it doesn't reduce my risk by maybe 1%, as compared to saying, oh, now I'm 95%.
It's true. Well, as you walk around, true. Don't forget the big thing is exposure. The other thing that can happen is if it's just a 2-month trial, and if all vaccines rely on principles of immunity and the immunity wanes, as exposures pick up and immunity wanes, that 90% can only go down.
Right.
And we started to see that early on. There were papers, there's one out of Denmark, I recall, that it was done in nursing homes. And the nursing home residents, the calculated vaccine efficacy was about 70%, but of the nursing home workers it was 90%. But we started to see, wait a minute, now the groups that we really want to protect, maybe the protection isn't as high as 90%. But having said that, they look good. It looked like the reactions in the arms and the lymph nodes and rates of Bell's palsy, what have you, were real. But coming out of the trials, I would interpret that as to be acceptable. I didn't voice. We were asked at the end of our November 19th hearings, did anybody on the majority witness side have any questions or concerns about the vaccine program? We remained silent. At that point in time, it was a press release. I had nothing to say. I saw the press release data, but being I guess, a wizened academic physician, we never comment off press releases. We want to see the data.
Yeah.
when we saw the briefing booklets, and the first one we saw was Pfizer, we saw something interesting, and that is we saw actually a little flurry of suspected COVID and confirmed COVID after the first injection on the vaccine side of things, which was interesting. Now, it was curious that maybe just people got confused regarding the reaction that they were having from the vaccine, or whether or not they came into contact. And then there were non-randomized reports that came from France and Israel showing the same thing. So I think there's now a general acceptance that there's actually a little bit of a susceptibility to COVID if exposed after the first shot.
I was just actually reading something about that, exactly what you're saying, and so that after the first shot you're actually more vulnerable rather than more protected. Yet there's no protocol saying between your first and second shot you should isolate, you should quarantine, you should do anything to protect yourself. And one of the things I'm really glad about is the details of the history of just your personal history and kind of the world you come from and how serious you take academic medicine and how serious you take epidemiology. I think that's important. And then seeing how this whole story unfolded when we were kind of like disoriented, like nobody knows what's going on. We're all concerned. We think there might be this really bad thing that's going to happen, and now we are where we are today. Okay, so we're at a point now where we have data. We can look at states like New York and California, which behave very differently than say Florida and Texas, where you're from. We have the vaccine now. We got hundreds of millions of people who are vaccinated. And now they've been vaccinated for some period of time, and we're seeing variants come, et cetera. Now I think there's perspective that didn't exist when you were testifying in front of the Senate, last November.
Yeah.
So if we kind of get into, for lack of a better term, a lightning round of topics here, with now you have the perspective to be able to look retrospectively and say, okay, here's what's going on. First, let's start in the non-clinical sense and saying, you've told your background, your story, but yet you're really being vilified, in pretty malicious ways right now.
Well, things were picking up through the year going into the Senate testimony where, there was talk around the hospital that I was, in a sense, a maverick. I was treating my patients, and I took on that responsibility. I carefully documented things. I was, in a sense, the medical monitor for the Baylor hydroxychloroquine trial. I was asked by officials to always say that my opinions were my own and not necessarily those of the institution. And I can tell you, my entire career, that is the case. My opinions are always my own. I never put out a position on behalf of any organization or employer ever. And as an academic doctor, I have a natural set of ties, and it's impossible to sever those ties that exist. So there's profiles. I think when things came to a head, there was a search. There was 800,000 profiles on me on the internet, professional profiles, over 16 million hits. So these connections are impossible to break. Having said that, my opinions, the words that come out of my mouth are always my own. So I honored that request of saying, and specifically at the Senate, I said, these are my opinions of my own and not necessarily my institution. And I've always sent out to various producers, some sets of this is my current sets of titles. But the problem is the titles and the positions eroded. So by the end of January, my contract was not renewed. I was previously employed by Health Texas Provider Network, which is a doctor group under the umbrella of the Baylor Scott and White Health System. So it's complicated. So doctors can't directly be employed by hospitals, but we're employed in physician groups that can be in a parent operating group. And I still have independently, I have and still do today, staff privileges to take care of patients at Baylor Heart and Vascular Hospital and Baylor University Medical Center. So those relationships are there. And so I literally had to scramble, and doctors in many sense they're like professional football players, professional athletes. I went on waivers and I got picked up by a private practice and was able to move my patients into a private practice on the same campus in an office that is on the Baylor University Medical Center with my full privileges. I changed my malpractice. So all my medical staff privileges, and by association, Baylor kept me up on their website as a cardiologist and all that. I had a separation agreement where we settled on terms because of the unusual nature of this. It's not like It's not like this wasn't a usual employment transition. And the stated reason why they didn't renew my contract, which was like an evergreen type of renewal, was no reason.
Wow.
And so I had developed a feeling that this was a retaliation for my efforts in helping patients and trying to treat patients with COVID-19, and how I had taken on a role with the U.S. Senate, the media. I had promulgated some important points. One in the Senate was the 4 pillars of pandemic response, which really was published in December of 2020, but emphasized that our public health response should always have something about trying to reduce the spread of the virus. A big focus on early treatment, because the sick people, those are the people that are our biggest concern. To do the best we can in the hospitals, pillar number 3, and then vaccination or herd immunity, but a balanced approach. And I had started through a series of publications in The Hill, a journal, a Washington journal, a window to America, basically telling them what I thought people wanted to know my opinion. And lots of people did. And so it wasn't just the White House, but the Senate, many others. And so I published in the summer. I said the great gamble of the COVID-19 vaccine development program. It appeared to me by the summer of 2020, we were putting all our eggs in one basket for a vaccine. We didn't see the investment on early treatments at all. We didn't see things moving along. There was no big American push to get Americans into research. There was no 800 hotlines, no public service announcements. And as it came forward, even when the monoclonal antibodies came out, they weren't widely advertised or made available. It just looked like it was going to be all about the vaccine.
Right.
So I made a professional transition, and through the course of December, January, and February, I didn't encourage or discourage the vaccine because it was a voluntary program, and people could sign up for it if they wanted to or not. And we didn't know much about it, honestly. We didn't know much about the mechanism of action. It's not like we had dozens and dozens of messenger RNA or adenoviral DNA vaccines. We didn't have any. And people started volunteering for the vaccine. And about 70% of my practice took the vaccine, patients in my practice. Various doctors and nurses did, but not all. And it was a voluntary program. I don't think anybody had too much of a problem with it. By looking back, we actually developed a mortality signal on January 22nd.
What does that mean?
That means that there were excess numbers of people dying after the vaccine that were being reported to the vaccine adverse event reporting system, exceeding the level of comfort. So if the universe of total number of shots that Americans take per year is roughly 278 million across 70 or so vaccines, that in the database, year by year by year, if you actually looked all vaccines, if you searched it, you'd see about 150 a year, sometimes 120, our average is about 150. We had already hit 186 with the COVID-19 vaccines alone by January 22nd. That was only with 22 million Americans vaccinated.
And do you feel that was only 22 million that were vaccinated at that point?
Yeah, I'm sorry, maybe 27 million.
Okay, and it's simultaneously, I've heard many experts say that that VAERS is also underreported. Do you agree with that?
It could be, but let's just take it on face value that it's every single one. One of the things that we learned is that the public program, the U.S. public program, is sponsored by the FDA and the CDC. They are the stakeholder. Pfizer, Moderna, and J&J, the vaccine manufacturers, they're not running the program. It's our CDC and FDA. So it was the first time that we had two public health agencies and actually a regulatory agency running a program. Usually the regulatory agency is regulating. They're not actually running a program. Right. So they're stakeholders, and they must have within these agencies a sense that this needs to be successful. The program did not have a clinical event committee. It did not have a day safety monitoring board. It did not have a human ethics board. So there were no safety guardrails in place there at all. And so, I've told a lot of people, I said, boy, if, I've chaired a lot of day safety monitoring boards. If I was tasked with this, 186 deaths could have been analyzed. And it could have been analyzed to, what were the circumstances? Were they allergic deaths? Did they die right in the vaccine center? Did they die a few days later? Did they look were they car accidents? Were they completely unrelated? They could have been reviewed. And a day safety monitoring board, if they would have come in a tight temporal relationship to the vaccine, and it looked like it fit the mechanism of action of the vaccine, is what we do, and what we know that it does cause production of the spike protein. A decision could have been made by an external body that would have recommended to the FDA and CDC to say, listen, stop the program or modify the program people of a certain age group are dying, or people with certain backgrounds are dying. But none of that happened because there's none of these external safety mechanisms.
I think further, as you're looking at it, in your mind, by definition, is this a vaccine? Is it gene therapy? Is it both? How do you view it?
The messenger RNA and adenoviral DNAs, from my understanding, are best classified as genetic therapy, gene transfer technology, because they do primarily involve transfer of genetic information into human cells. The prior vaccines were either a virus that was killed, a virus that was crippled that we respond to, or an inert protein, a protein that just, like a tetanus shot that we respond to. This idea of inserting genetic material into human cells and then having the human cell produce the antigenic protein, that was brand new. The difficulty, what happened is there's so much learning going on as the vaccine program rolled out. And one of the things we learned about is the virus is the ball, that's the nucleocapsid, and then the spikes on the surface. What we learned and what the scientific community learned is the spikes themselves were dangerous. So the genetic material that goes into the cell, whether it be messenger RNA or adenoviral DNA, tricks the human body into producing the spike protein, which is now known to be dangerous.
So the logic seems a bit concerning there, saying the part of the virus that is toxic to us and that could potentially kill us, we're going to now trick the body through gene therapy into producing the very thing that is noxious. So is the idea, well, we can do it and we can make sure the body only does it in small enough quantities that it can mount an immune response? I mean, what's the logic?
I'm not a vaccine developer, but I'm pretty expert in clinical trials and certainly have enough knowledge now. I think I'm on an 18-month sabbatical sojourn fellowship in SARS-CoV-2 and COVID-19. So I've reviewed thousands of reports. I've reviewed all the briefing booklets. I have over 45 publications in COVID-19. Now, not all of them I'm the first author. I was carried in a block for a large program out of Harvard called the Stop COVID program because we contributed data. But I've authored enough and been involved enough to have a sense of what's going on. And I think originally the idea was if it could be, if a small enough amount of messenger RNA or adenoviral DNA could locally produce some spike protein in the deltoid muscle and surrounding tissues, and we could form an immune response to that spike protein, we could get some immunity to SARS-CoV-2. I think that was the hope. And in fact, the initial studies on antibodies told us that, wow, the anti-spike protein antibodies were sky high with the vaccines, actually far higher than the natural infection. So this looked like something to behold. I mean, it's really, in a sense, reactogenic. It really stimulated antibody production. What had been found, and there was reports that came out that in women, the breast was being distorted afterwards. So it's like, well, it doesn't look like it stays in the arm very well. The breast is being distorted. And there was some messaging that came out that said, why don't we hold off on mammograms for a year because the breast is so significantly distorted from inflammation in the tissues and lymph nodes. And so that was
really, I mean, basically suggesting delay mammograms if you have vaccinated.
Yes, because it distorted the breast so much.
Wow.
So that information came out. And it came out through a series of various communications, official and unofficial, and I remember even discussions at my hospital about this. And then probably the next thing that came out was a paper by Ogata and colleagues from Harvard that showed in some volunteers that there was measurable spike protein circulating in the bloodstream for 2 weeks afterwards, after the first injection of
not just local, but
systemic.
Wow.
Systemic. And then there was a second injection, and then the antibody concentrations weren't measurable anymore. So maybe the spike protein was damped down by the antibodies. Spike was no longer measurable. So that paper came out. And then Pfizer did a biodistribution study on request of the Japanese investigators in animals to show where the lipid nanoparticles had gone. There were previous papers from China on lipid nanoparticles that suggested that they went to the ovaries and reproductive organs. And sure enough, the Pfizer biodistribution study, which was gained from a Freedom of Information Act from Japan to Canada, was reviewed by scientists and thought to be credible, that in fact that the vaccine, Pfizer vaccine, the lipid nanoparticles seemed to hyperconcentrate in the ovaries while they washed out of other organs.
Wow.
So that piece of information got on there. And then there was an autopsy of a man who died and this all is what happened this spring, while the vaccine program was being rolled out, where he was fully vaccinated, he develops COVID and he dies of what looks like an aspiration pneumonia, but then there's an investigation of where do they find spike protein and material, and the idea was it was found all over.
Wow.
It was found all over. And to make a long story short, things started really coming in hard. There was a paper and work done by Kyriakoulis and colleagues out of Athens, Greece. I'm a co-author, suggesting the nucleoside analog caps on the messenger RNA really keep the messenger RNA stable to produce spike protein for a long period of time. Messenger RNA normally is dissolved after one use and that's it. Mm-hmm. So that this stabilization made us concerned that spike protein was uncontrolled in terms of quantity and uncontrolled in terms of duration. Wow. It also makes us wonder if there's not reverse transcription, so there's a layering down of DNA into the HERV region of our chromosomes where there's almost a permanent install of the ability to produce spike protein, or potentially even the ability of messenger RNA to be spread by cell division through daughter cells. Because of so much is not known, that the vaccine development program was, normally it's 2 years of observation. It was cut to 2 months. If it's genetic transfer technology, we should have a 5-year observation period, including 5-year clinical follow-up on individuals.
So it should be more like 10 years would be the normal time span to study this.
The products have been around a long time, the technology, but they've actually just never worked in terms of, in a sustained way, producing a normal protein. So a normal protein, let's say Fabry's disease as an example, where we would use one of these products to produce messenger RNA coding for alpha-galactosidase. Well, the idea is to give the injections once a month and just kind of, you give an injection and a month later, in a sense, give a booster and keep producing this normal protein. Now what we're faced with is the vaccine, shot 1, shot 2, and now boosters, instead of producing a normal protein, of producing an abnormal protein, the spike protein. Now the spike protein is about 1,200 amino acids, about a dozen glycosylation spots. The code of the messenger RNA and adenoviral DNA that's explained to us is that still coding for the original wild-type spike protein. And it's not coding for the alpha, beta, gamma, delta, lambda, mu variants.
And they're different enough to matter.
They could be, certainly at the level of delta. If we go look at the data fairly, I think alpha, which is the British variant, appeared to be responsive to the messenger RNA and adenoviral DNA. Remember, the adenoviral DNA, whether it's Johnson & Johnson or AstraZeneca, always is a step down in terms of vaccine efficacy. If Pfizer and Moderna at 90%, they're always at about 70%. But even with the beta variant for AstraZeneca in South Africa, that was only at 50% efficacy. And so it's interesting. So, 50% efficacy, that's kind of a borderline. If we can't get 50% protection, it's a no-go. It's like a non-viable. And if a vaccine can't last a year, it's a no-go. Because all we're going to do is just keep creating a dependency on these boosters and keep changing things. So by the time we got to Delta, which came out of India originally, probably in response to mass vaccination in some pockets in Maharashtra.
That's what I was just about to ask. Is it from an evolutionary biological perspective that the vaccine program's causing the variant as compared to the variant is naturally occurring?
My understanding is a little bit different. I always point listeners to a paper by Neeson and colleagues from the Mayo Clinic and a company called Inference in Boston, where they have a huge database of sequenced SARS-CoV-2, like over 1 million cases. And I can tell you before vaccination, we would have a dozen or so variants, and each one had a percentage. But there was ecological diversity. And it's my understanding that the vaccine is considered a non-lethal evolutionary pressure, a non-sterilizing. Right? We knew the vaccines could not eradicate the disease. Once somebody got it, they couldn't. Nobody expected eradication. So the idea is if the vaccines just, in a sense, create an environment where the virus is mutating and makes mistakes, a mutant strain, which is already there, is going to find a vaccinated environment maybe more ideal to flourish. And in Maharashtra, India, they were using a Sinovac or Coronavac vaccine. And Delta seemed to flourish. Delta had originally 7 mutations in the spike protein. Then it was found to be an 8th one called Delta plus. And now British have described 20 additional mutations across the spike protein and nucleocapsid, so it's heavily mutated. Venkatakrishnan has shown what's called antigenic escape. It looks like at least Pfizer, it can't hit the antigens, despite that the spike protein has changed where the antibodies can't hit it. Our CDC directors come out a few weeks ago and said, well, yeah, with Delta, it looks like people can carry the virus and acquire the virus. That concession was there. We had Fahrenholt describe the Houston wedding, where a fully vaccinated wedding occurred and people developed Delta. We had the Democratic lawmaker flight from Texas to Washington. There was an outbreak of Delta, and the vice president scrambled to the White House and was concerned. A fully vaccinated naval vessel, 3,700 sailors. There was an outbreak of Delta there.
So what's the implication? So for the layperson, what's the implication saying, wow, we're having what they're calling now these breakthrough infections, meaning people are fully vaccinated?
But among fully vaccinated. So it's interesting. So it's fully vaccinated, among fully vaccinated,
Yes.
having these breakouts. And so to fast forward, there was a paper that's just come out from Chow and colleagues in Ho Chi Minh City. It's a unit of tropical medicine from Oxford. There was an outbreak in June of 2021 of Delta. And they had the ability to lock down the hospital, not let the workers go home. Don't go home. They're in quarters, they're being tested, and they're seeing who evolves. They had about 69 cases, as I recall, and they could tell who was passing it to one another because they even had detailed sequencing. But the important point is, these are fully vaccinated people, on average 2 months after AstraZeneca vaccine, fully vaccinated healthcare workers. None of them developed severe disease, but they developed symptomatic disease, but they showed a viral load that they estimated in the nose and mouth of Delta at 251 times that of the viral load from previous variants.
Wow.
In previous patients in the unvaccinated era. That was published in Lancet, again, one of our better journals. So right after that, there was a preprint that came out from Guangzhou, China. Liu and colleagues published a similar observation, although with Delta, they think it's 1,000-fold increased viral load. Now, they didn't indicate who was vaccinated, who was not vaccinated in that group of subjects, but we know in Guangzhou, China, that over 80% of the whole place is vaccinated. So it's very likely people in that group were vaccinated and, in fact, were contracting Delta. So there is the very real and present situation where those who are vaccinated now using the existing vaccines can acquire and carry and get sick with the Delta variant. The CDC is telling us in the end of August of 2021, we're 99.1% Delta, so it's all Delta, that in fact the vaccinated can participate in the Delta outbreak either as carriers and spreaders or as those getting sick themselves. And the CDC did tell America that's happening because a paper by Havers and colleagues from the COVID research network that the CDC coordinates with published that those hospitalized with Delta in June of 2021, that approximately 23% were partially or fully vaccinated. The CDC has on their website, they have thousands of cases of vaccine failures that have either been hospitalized or died. They've published it at separate data sets. And sadly, about 80% of those are age 65 or older. So those who we want to protect the most with the vaccines are failing. So our CDC is trying to tell Americans, and our CDC director has said this, is that vaccinated can carry Delta. They're telling us that Americans can get Delta who are fully vaccinated. What's been challenging, and I've just given your listeners the information with the citation, so they can go to the CDC website, they can go to these papers that I've quoted, okay? That's different than the misinformation. So a misinformation was a talking point that was said by various individuals that this is a crisis of the unvaccinated. Right. That stated 99% of those hospitalized were unvaccinated. There's billboards up that say, over 90% of those in the hospital are unvaccinated.
Well, our president just recently, alluded to, the unvaccinated being the root of the problem, and that his patience is wearing thin. So
right.
Tell us how that's misinformation.
Well, as patients get hospitalized, if they don't have their vaccine card, they don't have a ready way of proving their vaccine status or not. And people vaccinated or unvaccinated are very wary of vaccine discrimination. So in Texas, we actually have an executive order on this. in April of 2021 saying there will be no vaccine discrimination in our state offices, vaccine discrimination. So it can be discrimination against an unvaccinated, but also vaccinated. So in my practice, I have had patients who I want to get a monoclonal antibody infusion. Doesn't happen all the time, but it's happened. And the center that they get sent to will ask them if they're vaccinated or not. And one of the decisions is, well, if they're vaccinated, they may not get the monoclonal antibody infusion. They may get remdesivir because there's the thought that maybe, but the patient and I really wanted the monoclonal antibody infusion. So people actually may not disclose their vaccine status in one direction or another. They may not, and there's no proof of that. So unless we merge the hospital data set with the vaccine data set and really have some, which is what the CDC did, that number looks like 23% in June. I can tell you as Delta shaded in July and August, I anticipate that 23% is going to go right up to a much higher fraction. It'll probably approach the same fraction of the population that's vaccinated, just like in Israel. In Israel, the proportion of those who have COVID-19 roughly matches the proportion of the vaccinated population. It's about 80%.
Wow.
Implying there's no differential of those having COVID based on who's vaccinated or not. So the listeners can try to draw their own conclusions. I mean, one would like to think that the vaccine really suppresses COVID-19 infections. There's hardly any COVID-19 infections in the vaccinated. Well, it's not the case in Israel, and it looks like it's not the case in the US.
That completes part 2 of my 3-part interview with Dr. Peter McCullough. I have to tell you, when we were recording this, I was so excited to share this with you. I'm glad that you're here, and we're not done. There's another part coming with Dr. McCullough. We have that to look forward to.